Okay, so we're going to start with this man. This is an obese patient with it's a strange looking urethra, with a very large gland. He had a relatively high PSA. We did an MRI, and we found a suspicious Pyrex 4 lesion. We did a biopsy. One of them had a Gleason 4+3 in a small foci focus, and it was not enough for the pathologist to tell, of course, or he was cautious to say, I don't know what the final histology will be. So we discussed the options at large. We offered him to do a robotic radical prostatectomy, despite the big prostatic size, 190, something like that, as estimated by MRI. And but he was very reluctant, and he managed to visit other colleagues and discuss other options. Of course, radiotherapy was an option, but with such a large gland, everybody discouraged him to have radiotherapy with such a large gland. So we finally got to the point where it was agreed that he would have a HoLEP, and then he will undergo radiotherapy and hormonal blockage, unless something changes in the histology of the adenoma. Well, we'll have to see. So this is a case of a 67-year-old man with some cancer in the biopsy. As I said, he visited many urologists. They thought that operating such a large gland is not so easy. We were happy to do it robotically, as we have done other cases like that before, but being obese and is not a very good surgical candidate, and so this was the final option. Sometimes in patients with extremely large glands, you cannot apply the protocols exactly the same. This is the truth about medicine. No, we have some guidance, we have some guidelines, but you can never be dogmatic about how to behave and what to do, because sometimes we find special cases. Here I am developing the posterior plane, and I had a conversation with a colleague from the US recently where he told me that he was breaking a lot of scopes because of the mechanical dissection. And here's my piece of advice. When you're going to dissect, you have the line of attack, you have the adenoma, you have the capsule. So how can you dissect this plane? Well, one thing is, if you have to push, you shouldn't be pushing here, for example, because it's not mechanically clever, it's not going to work. But if you put the upper part of the scope there, you contact the capsule and then you slide the scope, you will be able to dissect a little bit better, although you see sometimes mechanical dissection has its trouble. Let's try it here. So here I am, you see, putting the tip of the scope a little bit downwards so I can push more efficiently. Maybe this is not a very good plane. The other way of doing it is to put the scope here, you see, and then move from side to side. This way, you see, you're going to generate some mechanical stress between the capsule and the adenoma, and then you will be able to dissect. But of course, you should never do a lot of force, a lot of mechanical force to dissect, because that's what is going to cause trouble. And that's why I prefer the energy of the holmium laser, because when you want to write with a pencil, how do you hold the pencil? Do you make a fist and hold the pencil with your fist, or do you grab it with your fingertips? So the idea is that when you want to use the laser to be very precise, to fire where you want to fire, you have to be equally careful in the manipulation of the scope of the camera. You see, holding it with your fingertips, not with the, as carefully as possible. Holding things with your fingertips gives you a lot of sensitivity to know what's going on. You get probably much better haptic feedback than if you hold the scope or the camera with your hand or with a fist. So I like to dissect with energy after having done a lot of mechanical dissection to do GreenLEP over the years. I probably did thousands of cases of green light enucleation. Probably, I don't know, 3,000 cases, 5,000, 4,000 cases. And I found that it was interesting because it seems when you have a high volume of patients and a lot of operations in a certain period, you develop the sensitivity to do it better. And if I was on holiday, for example, when I returned from the holiday, I could feel that I was a little bit more clumsy, it was more difficult to keep the same proficiency at careful mechanical dissection. But of course, when I started using holmium and looking at the excellent, careful, gentle dissection that you can have with holmium, I switched from mechanical enucleation to energy driven. Of course, sometimes you don't know exactly where is the proper plane, but more and more I think with experience you are quite certain of where you are and quite happy to recognizing the proper plane and not needing to do mechanical enucleation. Here, as in every obese patient, the mobility of the scope is a little bit limited by the fat pads, in the perineum, in the legs, all around the prostate, the perineum, which is going to limit the mobility of the scope a little bit. Also, this colleague from the US told me that he used to do perineal urethrostomy. Of course, I took a picture of this patient so you can see what obesity looks like in my country. Maybe in America, obesity reaches, more epic limits, or bigger, fatter people. And then, of course, we probably don't do that kind of patient here, so I cannot speak from my own experience on super fat people. But he was telling me, I managed to do a very, very large gland in an obese patient without having to do a perineal urethrostomy. And I think that might be another advantage of the en bloc approach. So you see that you can possibly reach the bladder neck much better in patients with very large glands, because you don't have to get over the middle lobe to enter the bladder. The length of the posterior urethra is much more than the anterior urethra. Of course, if you get under the adenoma, it's a straight line to the bladder. You don't have to go up and over the middle lobe. This is the sphincter edge. I'm being very careful to try to preserve the sphincter the best I can. Here there is possibly some adenomatous tissue there. So I'm going to just incise here, following the white line, you see, trying to get all the adenomatous tissue out. But of course, what I'm trying to gain is some access to get to the proper plane, which seems to be behind this. This is a nodule there. You see, we don't want to leave it attached to the capsule. So of course, trying to liberate here. Initially, I like to dissect the posterior apex a little bit, so we gain access and we gain the mobility of the apex. So the apex is more mobile, and then we can push it a little bit more medially to enter also the anterior plane. Now also here, you see, I like to connect the line of dissection in the lateral plane to the posterior plane. So we could follow this line, you see, from the posterior dissection to the lateral dissection without any big step or big, you see. Doing that dissection is not putting a lot of stress in the sphincter anteriorly here, so it's difficult to break it here. Now, of course, when we want to do the anterior part, we have to be careful and we have to detach here. When you go up and you reach near 12 o'clock, you have to cut a little bit more horizontally for some millimeters until you can enter here, you know, progress anteriorly a little bit, and then of course you have to follow the direction of the fibers of the capsule to go anteriorly as much as you can. You see, as the sphincter becomes more and more liberated, more and more free from the apex, you have better exposure, better access, you see, and it's more and more affordable, more and more possible to get up there and to connect anteriorly. So far so good. I think we are enjoying the pulse modulation system from Quanta system. They are the settings that I'm using are 2 joules and 50 hertz. See here, there's some adenomatous tissue anteriorly. So let's work on this anterior line slowly. You see here, for example, we know that we are in a good plane here. So let's take it towards the midline anteriorly and keep the fiber up. You see now the sphincter is separated from the apex, so we are quite happy that we're not going to stress the sphincter anymore. I'm coming up, all the way up here. You see, in some moments, I might not be seeing what the fiber is doing, but I know exactly where I am. So I'm quite confident to work even when I don't see the fiber for a little while. Sometimes, if you are always trying to see the fiber and what it does, maybe it's going to be much more difficult sometimes. So you see, this is the beauty of the circumferential dissection of the en bloc approach, because you know more or less where you are, you know the shape of the capsule, and you're just progressing. Sometimes the tissue gets in the way, you don't see exactly what's happening over there, you see like now, but you know that you are doing a movement that it's totally safe, because we are following the circumference of the prostate, and it looks safe. Here you see the plane is not extremely beautiful, but it's developing very nicely. And here, as I come anteriorly, so I have to keep up as anterior as I can, and then as we get better access, you know, sometimes there's a little bit of tissue that wants to remain there at 12 o'clock, but it's a matter of course, if you see there is a little bit of tissue and you have already established a line that is more proximal than this tissue, you can also, you know, leave it for the end. So you can continue with your dissection as long as you have connected with the right plane after the remaining tissue. I don't know if I can explain myself properly. And then yes, so we'll have to review here at the end to see. You see, it looks good to me up there, but we have to unify the line of dissection anteriorly. So I'm going to work a little bit on it. Sometimes anterior plane needs a little bit of work, which means going back and forth like this, you see, to try to make sure that the anterior line is connecting properly to the lateral and the lateral is connecting properly to the posterior, you see, and we are following a nice, apparently nice line here. And then, of course, you have to work to connect with the other side and to make sure that the line you're following is the correct one. But you see, from the beginning, we haven't seen a lot of bleeding. We have excellent visibility. The irrigation of this very small space is providing excellent visibility. Here I'm not sure if this is adenomatous tissue. It looks like a little bit of adenoma there. So we are constantly trying to challenge the plane that we have and to see if the plane is correct. Here, as I said, you see, sometimes if you work a little, if you are a little bit stubborn to try to construct a nice line of attack, line of dissection, it looks a little bit yellowish, you see, and I like to remove the yellow tissue. Who knows what that would be also histologically, no? But here I'm coming up, I look at around, you see, to follow the uppermost fibers here, you see, trying to go and search for the best possible plane anteriorly. Yeah, there's some limitation to my movements as well because there's a lot of fat around the perineum, but slowly I'm getting where I want, which is close to the capsule anteriorly. You see here, it's not a matter of bringing the laser up and forcing the sphincter. You know, sometimes you can split the sphincter in two if you do a lot of strength anteriorly, if you push too hard. It's more a matter of trying to get above the adenoma and when you lower the adenoma, everything seems to, you know, position itself properly. Here. That looks reasonable to me, you see, but we have to challenge, constantly challenge the quality of the plane if we're going all the way where we want to go. Okay, so let's check what happens with our line of attack from the side, looking at the side, coming a little bit more anteriorly, crossing over, you know, to the other side posteriorly. Look at the beautiful hemostasis we get. The nice things of pulse modulation, the nice aspect, the one I like more is that you get pretty good, this is probably the area where we were dissecting mechanically. You get pretty good first pass hemostasis, which means that you can focus in the dissection. You don't have to be dissecting and controlling the hemostasis because it does get controlled very nicely when you are dissecting the plane for the first time. So this is the first pass hemostasis. Here you see that the posterior plane was a little bit deeper than the lateral plane. That's why we had to come out a little bit and that's why you have to try to carry a uniform depth in your dissection. So don't get carried away with one side, you know, or anterior or posterior. Try to go around several times, you know, trying to develop the plane and trying to follow the best possible plane. You see, to a uniform depth. You know, here, let's come to the other side and continue with the dissection. It's a very large gland, but I have to say that doing these very large glands becomes much easier when you have a tool like the pulse modulation, because you're much more relaxed and much happier in terms of the safety of what you're doing, you know, the bleeding control. Of course, if you see properly, you see the anatomy and the detail much better, and the chances of having problems with the depth of the dissection or not recognizing the plane are, you know, diminished. It's difficult to reach there with the fiber. No. Let's see. Without pushing too hard, so be careful with that. Come from a distance to see it's possible. There we are. We couldn't stop it, huh? I don't reach there, so we'll see. So progressively and carefully we will continue. It has a certainly very high anterior tissue there, so let's see what is the best way to get to that level, because I'm having trouble and I don't want to use a lot of force reaching so anteriorly, you know, reaching so high without doing a lot of pressure. Sometimes you can see that the lens, one of the corners of the lens starts looking black, and that's because you are forcing the scope too much. So I try never to see that if I can avoid it. Sometimes force is an enemy of, and also even if you have to leave some tissue anteriorly in a difficult case, which is not so usual, then of course you can come back and have a look later, and sometimes it's easier to remove any residual fragment towards the end, you see, than to struggle too much. Let's move on a little bit with the lateral plane. Here we saw a bleeder, so come back to check. You see the quality of hemostasis is amazing. The laser opens the plane where it has to be opened, following the anatomical plane between adenoma and prostate. And it's looking better, huh? Let's see if we can come up there and release this anterior mass. The nice thing of this operation is that there's no two similar prostates. You know, every prostate is different and every case is different, and you have to adapt to the anatomy of the prostate, to the anatomy of the patient. Sometimes it is a little bit challenging to do what you want, but most of the times we can, you know, get to where we want if you're patient, work carefully, progress carefully. So you see, approaching the anterior carefully. Okay. It's so easy. Almost there, I think. It's a relatively difficult anterior plane, but we are getting there. I think we are succeeding to take the anterior tissue. You see, normally you wouldn't have such limitation in a normal patient, but this is an obese patient, so the mobility of the scope is limited, so that's why we're having more trouble accessing this. I think it's looking good. We will check at the end. Now I'm working to try to do a uniform anterior line of dissection. You see, to get a uniform line that will connect to the lateral line of dissection. And progressing nicely and carefully, very nice. Here we are connecting with the anterior plane of dissection. We have to check if we're achieving a similar thing on the other side in a moment. So, here again, look at the size of this varicose vein. Here we are coming down, down, trying to connect with the line of dissection. Of course, here sometimes we can find a discrepancy in the plane. That's what I call a ligament. And that is because sometimes the middle lobe pushes downwards and the lateral lobe pushes laterally. And when you follow the plane below the lateral lobe, sorry, the middle lobe, it looks as if, you know, the plane would have to follow this curve, you see, but then you go out and there's more, you know, so this case is not very visible, but often we see that situation where the lateral plane extends very lateral and there's a, it looks as if there were two planes. And in the middle, there's a fibrous tissue, what I call the ligament, the interprostatic ligament. It's not an anatomical ligament, but I found that it was a nice way to explain it to people who are learning, you know, when you're dissecting the posterior middle lobe and you reach a moment where it seems that there is another plane outside and there is this plane inside, you see? So you're confused. So just cut in the middle, connect, because you are dissecting two different spaces, the space below the middle lobe and the lateral space. That's very interesting. This, we would never see that before with the three-lobe technique, because typically the incision would go right there, right at the ligament, right at the area where between the space developed by the growth of the lateral lobe and the space developed by the growth of the middle lobe. So here we are coming up, up, all the way. And it's looking good. Again, you see going around the adenoma, following the circumferential line of dissection. Here, of course, you have to keep in mind that the adenoma is spherical or pseudo-spherical, but here we can tell for sure that this is the entry into the bladder at 12 o'clock. We are above the anterior commissure. Now I'm not forcing at all my scope to reach up there, and that's because having the scope on top of the adenoma brings everything downwards, you know, and then instead of having to tilt the scope upwards to reach the 12 o'clock, by lowering the adenoma, the 12 o'clock region is going to come to you, no, more or less. So I don't see that often that I split the sphincter at 12 o'clock trying to reach the anterior, the uppermost. This is one of the advantages of the en bloc technique. You don't have to do extreme force to reach the 12 o'clock, you know, and which sometimes splits a little bit the mucosa of the sphincter at 12 o'clock. So here we are, continuing in our continuing mission. It's like Star Trek. Okay, here the U is far, huh? So we are quite happy. Look at you see the volume of this adenoma. It's quite big and round, but we are progressing really nicely and efficiently, I would say. Nice visibility. It's like yellow tissue there. If it's too small, you can, you know, vaporize it like this. If it's bigger, maybe you can try to correct your plane and try to take it under that anomatous tissue, but sometimes you have to judge, you know. You don't want to go too deep. But let's see, we have to understand the anatomy and understand that we are looking at a much magnified image of the plane. It's very magnified, so things that look very big on the screen are relatively small. You know, the fiber has 0.5 millimeters, so it's very, very small. Whatever we are seeing, it's rather small. So I think all the adenomatous tissue should be taken out, but not justifying, you know, leaving tissue behind. But what I'm trying to say is that you have to distinguish, you know, what is important and what is not important at all. The penetration of the energy in the tissue is quite shallow. It's not deep. It's not deep at all. So just enough to coagulate. And here we are coming towards the side. Let's see if we can release the side. You see, it's a matter of going around the adenoma. Of course, these very large prostates, they don't leave you a lot of space, so you have to learn to navigate around the adenoma to find your position and to find. But usually, even in the very large glands, you can find your way. Yeah. Here it looks that we are following the right direction, reaching the bladder neck area. Also, as we progress, the adenoma gets more mobile. You know, it hangs from a smaller pedicle, a smaller connection area, and it's more easy to tilt it from one side to the other, to push it, to take it out of the way. So as we progress, we are managing to, you see, here, beautiful. Now again, never stay too long in the same place, you know, you just go around, look how you can improve the situation every minute, you know, every minute things should be better than before. And doing some incremental improvements, incremental steps, you know, you can make things better and better and better until we reach a point where we have finished the enucleation. No? So here, again, you see, if you follow the middle lobe, it looks like the plane is coming this way, but then the lateral plane is going much more lateral. So I like this concept of the ligament because it warns you about this possibility. So when you find it, you're not confused, you know, and you're not thinking that there's something wrong with you. It's the anatomy of the adenoma. Look at that. It's a big prostate. You see, I am positioning myself right at the edge, trying to keep the line of attack in the middle of the screen, so I can see both adenoma on one side and capsule on the other side, and I can develop this plane very carefully. I don't use force at all, you know. Sometimes I have to say in the very large glands you can find some steps where it is a little bit more difficult, but I think the advantages of the en bloc approach surpass the disadvantages, you know, or how do you say, compensate the disadvantages. A little bit of yellow tissue there. Here, I don't like that one. Let's come this way. Maybe you see sometimes. Of course, here you start to see that the plane is maybe too deep. So, but again, as I said, there's nothing wrong in challenging your previous plane, in exploring a little bit. Sometimes we find these nodules. These are adenomatous nodules, you see. And I like to take out if I can. This, of course, complicates the operation a little bit. But if you don't take them out, they can grow. And this is a biologically fast-growing prostate. So see, these nodules thin the capsule a lot, so you have to be careful. Okay, this also maybe is another nodule. Well, it's a very large gland, and we don't want to, of course, lose a lot of time and get carried away with small details, you know, but I'm quite, how do you say that, convinced that it is worth it to remove this nodular yellow tissue if you can. This thins the capsule a little bit, but see here's where we want to be. I remember when we did open surgery, at the end of the enucleation with the finger, you would put your finger in the fossa again to check for nodules. So these are these nodules. Okay, so here we are. It's virtually nothing, but yeah, almost there, almost there. So things are getting better now that we have removed this nodule here, and to try to connect with the previous plane. You see here we are under the nodule. There's still maybe some little attachment there. Let's see how we are progressing. As I said, sometimes you liberate on the other side, the prostate gains mobility, you can tilt it into the bladder, and then accessing difficult areas can be easier. Here again we continue. It's a very nice looking plane up to the bladder neck, I think. Here we are coming up. We see that is bladder neck, so we are reaching the bladder neck also posteriorly. Look how, as the prostate lifts laterally, we have better access from this side as well, you see. So don't get stuck in one single place, you know. Try your best and then move on. Go to another place, and then when you return, things will be easier. You know, don't be so stubborn to remain in one difficult area and try to finish that, you see, because here we are under the bladder neck, almost finishing the procedure, the enucleation part. Let's see where we are. here. Here you see there's only a little bit of attachment down here. So let's again gain 1 millimeter at a time, and where you are, do it confidently. You don't have to do anything you don't believe that it's the right thing to do. It seems obvious, but don't try stupid things, just stick to the plan, stick to the method. Follow the basic rules, keeping good hemostasis, keeping in the plane, correcting the plane if it's wrong, and improve the situation every minute. And then finally you will manage to finish the procedure. Here, what I'm trying to do is to lift a little bit the adenoma from one side, to push it in the bladder like that. You see, now I push more, and then this is going to rotate the prostate. You see, this lobe went inside, and then instead of pushing that one from that side, what I'm going to do is continue the rotational movement here like that, you see, and then it goes in the bladder. So it's a beautiful enucleation case. Here we are at the sphincter. You see, we managed to preserve the mucosa of the sphincter. There's some reasonable shattering of the mucosa because of the pressure and the movements we had to do. Look at the beautiful hemostatic properties of this laser. Let's look at the UO. Where are you? Here and here. Okay, let's morcellate. No need to do a secondary hemostasis. If we look anteriorly, it's pretty good. There is maybe a little, déjame la fibra un momentito. There's maybe a little bit of tissue around here that we're going to just remove it now. I think it's going to be easier to finish that. I didn't see it before. But otherwise, very good. This is some anterior near the sphincter tissue, but I don't think that's obstructive. You see, many surgeons try to leave a little bit of tissue very close anteriorly at 12 o'clock near the apex, because probably respects the sphincter even more. But there we are. Also, the improved cutting properties of this holmium make this trimming exercise much easier. Vale, vamos a cambiar. So I'm going to change the camera. Déjame una gasa para secar aquí. Venga, dame el nefroscopio, por favor. Muy bien. Venga, perfecto. Bien. Ahí está. Aquí solo vamos a cambiar la luz, porque aquí no hace falta cambiar el agua está aquí, ¿lo ves? Y aquí no hay agua.
Sí.
Ok. Cierro. Venga. Saca. Bien. Ok. We did a relatively fast change with the morcellator and, sorry, to the nephroscope. Aguas altas, ¿sí? Nuevas, rellenas. And the morcellation starts. Here. You can see the big gland and how morcellation is being quite good from the beginning. Let's see. I'm trying to keep the morcellator tip a little bit inside, you see, to make sure that it is well introduced in the bladder. Keep it in the center. Because sometimes if you try to work very close to the lens, the adenoma is going to clash with it's going to collide with the tip of the scope. So you need to go a little bit further than you might intuitively feel it's safe at the beginning, of your experience. So, but my scope is a little bit tilted up, and I have two corners, you see, at the side of the morcellator blades that are quite black, which means that there's no bladder nearby. So This piranha morcellator is wonderful, as it chews the tissue very fast, and in these very large glands it's going to take a while. We usually take out about 10 grams per minute, which means that if this is a 160 adenoma, for example, it'll take us around 16 minutes, we will see. This providing that the morcellation goes well and it's efficient, but it's looking very good. So you see, there's usually no problem in tilting the adenoma into the bladder. This is one of the criticisms to the en-bloc technique, but in my daily practice I don't find. But of course I found that lifting the adenoma, trying to bring the lower part of the adenoma in the bladder with your scope and then pushing would give you the best results. And of course, following the rotational movement with the rest of the prostate will help you tilt everything into the bladder. In extreme cases, we have had to morcellate with the adenoma in the fossa, which is not so bad either, because there is, I mean, the prostatic capsule doesn't fold like the bladder, so it's very difficult to catch the capsule with the morcellator. And also the irrigation is excellent because you're irrigating an even smaller space. So typically you morcellate a little bit until the adenoma gets small enough to be able to be pushed. But as I said, I have probably done, I don't know, less than 5 of these situations in my life, which means that it is quite rare. Of course, very large glands are always a challenge, and you have to take them seriously, you know, be properly equipped to do it, both with the proper instruments and the proper experience that can leave you there. But it's not so much difficult than maybe you can have some anxiety at the beginning when you do these large glands, and my recommendation is to keep calm and to trust the method. You know, if you keep good hemostasis, if you keep improving the situation every minute, you're going to be able to reach at the end. Maybe it'll take a little bit longer, but you shouldn't be very afraid. Of course, if you are a slow enucleator because you don't have a lot of experience and it takes you, 2 hours to do a 70-gram prostate, then it's not advisable to tackle the big glands until you get a little bit faster with your enucleations in the smaller glands. You know, when you have the proficiency, the skills, the confidence, when you have developed the necessary experience, then moving on from 70, 80 to 150, 200 is not such a big leap, you know. But don't underestimate also the teaching power of smaller cases, you know. So if you're doing HoLEP in smaller glands, each case is an opportunity to learn and to develop your skills to a level that will allow you to tackle bigger glands with confidence. As I said, and I like to say, with HoLEP you have to be present in the operating room. You have to, you cannot keep working and forget about what you're doing. You cannot go to the automatic mode, you see. This was very common with green light vaporization. It was slightly boring to have to vaporize larger glands, and you could get bored. And I developed this idea to be present, you know, to check every second what's going on. Is my distance from the fiber to the tissue correct? Is the movement of the fiber at the right speed? Am I achieving the best big bubbles that show you that you're vaporizing efficiently? So here is the same. You have to be present, you know. Is the morcellation going well? Am I sucking too much water out, or, you know? And also when you're doing the enucleation phase, It's very important to keep your eyes on the details from the capsule, from the anatomy. You have to see with the corner of your eye as well, you know, to check and to understand what's going on. Here you can see bladder neck. We're almost inside the prostatic fossa. It's such a big opening that the adenoma can, and it's a very safe position because I can see the bladder neck with my eye looking down. You know, I can perceive the white there. I know that I am a couple of centimeters above it. And also the tissue is between the morcellator blade and the bladder neck anteriorly, so it doesn't go anywhere, you know. It doesn't tend to go away from the morcellator blade. So we are progressing very nicely. I'm sure this patient will go home in less than 20 hours, I guess. We will leave the catheter overnight. Tomorrow morning we will take it out and he will be able to go home. It will be interesting to see what the histology of the adenoma says and then what is his remaining PSA. And but if the tumor is Gleason 4+3, I think he should undergo active treatment. And if we do radiotherapy in such a large gland, it's a recipe for trouble. Whereas if we do the enucleation first, of course the radiation will, I mean, we probably don't have to go back to operate this man again, no? Which would be the difficult part after radiotherapy, or the risky part. No? Here we have some nodules inside the fossa. Here you see it's easy to catch them and to morcellate them. Interestingly, even when we had only 2 pieces of tissue, this is very hard. Or se está llenando el bote. Se está llenando el bote de tejido, ¿no? Mejor. I think the suction is not so efficient anymore because the canister is full. There's only 1 little piece, but it's not being very efficient morcellation anymore. So maybe, unless you see the view is getting worse because I'm sucking too much water and the bladder is emptying. So cambia un momentito la cestita y terminamos. Venga. Let's change the canister because it's almost full to the top. And the tissue in the canister is preventing the vacuum to reach the tip of the... So just, yeah, we have to stop for a moment. Se está moviendo un poquito. Ya estamos terminando, pero me queda un poquito. ¿Cómo va? Okay, you see, so we have lost a little bit of visibility. Here is the piece. Let's see now with better suction. It is a beach ball, huh? So it doesn't want to come out.